Hi, this is Roger Green, host of the Surfing the Mesh Tsunami podcast. This week we are offering 5 conversations from episode 13, our preview of Global Fatty Liver Day 2023 from Global Liver Institute, with Jeff McIntyre, Mike Patel, Louise Campbell, and me, plus from the vault, a look back at our wrap-up coverage of International NASH Day 2023. This conversation centers around the Global Fatty Liver Day 2024 theme and the rationale behind focusing on screening. It starts with Jeff McIntyre describing how much has changed in MASLD in the past year and why these changes call for a new focus. Jeff identifies the breadth of the global challenge of treating MASLD and related conditions, which is far broader than, as he puts it, just having one medicine for one aspect of the disease in one country. To Jeff and GLI, the best immediate path forward is to bring more patients into the system through screening, which provides the rationale for GLI's theme for the day, Act Now, Get Screened. The rest of the conversation centers around whether the clinical care pathways are sufficiently organized to support a large increase in volume. Hint, they're not. And how to mobilize patients better. Hint, here's that slogan again, Act Now, Get Screened. Global Fatty Liver Day, the event previously known as International NASH Day, is the preeminent patient advocacy event on every year's calendar. This conversation whets our appetites for this year's event, so just sit back, listen, learn, enjoy, and when you're done, join the dialogue in our LinkedIn discussion group. I want to turn the floor over to Jeff and talk a little bit about the theme of Global Fatty Liver Day 2024 and kind of how you got there.
Jeff McIntyre.
Well, I want to say that I think that this is a great time of transitions in respect to the honors and the remembrances going out for Stephen right now. There has been a nomenclature change, and so we are reflecting that. What we were talking about in terms of Global Fatty Liver Day used to be International NASH Day, and so it's now Global Fatty Liver Day to be a little bit more inclusive and surrounding of more of the patients and more of the disease states. So when we think of kind of the transitions, what is most needed in terms of fatty liver disease and where the priorities are, that's a great, honest conversation, I think. Now that we have arrived at a medication which is helpful but not a panacea, for us, our goal and the thing that we have arrived at for our theme this year is basically to act now and get screened. When you look at the efforts around Rezdiffra, or what was resmetirom at the time when they were going for their approval, one of the things that they talked about with the FDA quite a lot, or that was talked about around the FDA, is kind of narrowing that patient population to specifically get at patients in the system. That's what it was. This wasn't going to be trying to address other early F2 necessarily, or decompensated cirrhosis, but we needed patients in the system to be able to help them with that. And so for us, our question then becomes, how can we get more patients in the system? How can we screen? How can we get folks aware of their liver, aware of their liver health more aggressively? And how do we do it in a coordinated global effort? So often we see these sort of patchwork initiatives come up. The community organizations do great things. Some of the national groups do great things. But in order for us to truly holistically attack this disease, we need to move on from just having one medication for one aspect of the disease state in one country and begin to really screen people to be able to address the issues that lay before us in terms of patient access and kind of set the ground, if you will, for other countries and other at-risk populations. So this year, Global Fatty Liver Day, go get screened. That's the thing.
Excellent. So one question that comes to mind is we've done a fair amount on this podcast over the last couple of years about the whole idea of clinical care pathways. But we had a couple of episodes earlier this year where we asked treating physicians how many up referrals they'd gotten from PCPs based on FIB4s, and the answer was universally 0. Now, I think part of that's because we didn't have a drug. But even with the drug, if you look at the groundwork that Madrigal needs to do for Rezdiffra, it doesn't have a lot of room in it right now for getting people into the top of the funnel. Michael, I'm guessing that's going to be one of the things that comes up. And did you like the way I did that without a G on the end, I'm guessing? That's going to be one of the things that comes up in Barcelona, the specific question of how to drive the top of the funnel.
Well, one of the topics I just looked again this morning, it's the diagnostic gap, including AI, the use of AI, but it's availability, which I know Louise is focused on quite a bit too in her area, is the availability of the tools to be able to do those assessments, not just the biomarkers in some places like Canada that you still can't even get that unless you pay for it, but even the availability availability of things like FibroScans or, other VCTE methods.
So, Jeff, I guess a part of my question then becomes, as a patient-centered organization, how much do you see of the work as being to get patients to get themselves screened versus working with the other stakeholders to make sure the prior conditions are there for all that to go right?
Oh, that's always a tough question for me, Roger, because I think my gut instinct, and this is just my reflex on that, is every time I feel like that question comes up, what I hear, and I don't think you're doing this, I'll say, but what I hear when I hear that coming from medical societies or from clinicians is, why can't patients just pull themselves up by their own bootstraps and go in and make it happen? And I think there are too many systemic sort of firewalls that still exist. That is not to deny patient accountability in terms of we can do a better job. We can do a better job as a patient organization. And this conversation is a part of that. But I find it to be a little off-putting in how much finger pointing goes on in the field. Well, if primary care did better at this, or if the endos did better at this, or if we had a diagnostic that could serve all the disease states and the FDA could come along and do their thing, without really focusing on the steps that we could take in order to support that. I think in order for primary care to do this, for instance, for patients to be more assertive and get screened, we as a collective, as a field, are going to have to hand that process to them turnkey. We've got to make it easy. This doesn't really exist in the medical field in general in many ways. There's some places where we've had big breakthroughs. I'm thinking, insulin, for instance. But even in the case of insulin, we still have roadblocks that come up. We still have issues with that. And so for patients to truly be able to get that service, to make it easy, we've got to do it at primary care for them in order to be referred to the specialist. I don't think Rezdiffra is going to be something that is seen in the primary care setting very much, but our hope for Rezdiffra was often not the medication itself, but in terms of the doorways that it could open. And that's the place where we are right now. And that's where we need the coordination and the better effort, is to make sure that we open those doorways so we can have the conversations about screening, for instance, getting more patients in the system, about reimbursement, about payers, about all these sort of things. And then as we're doing this here domestically in the US, how can we be setting the stage for if and when this happens with the EMA? And so as we've done this is kind of a templating exercise almost. So we've got, a handful of other therapies that are in phase 3 right now. So hopefully once we're able to sort through and troubleshoot all of this, then we can come back and it'll be easier for these other therapies to be able to make their way forward as well. And that includes, the combination aspect. I don't think they cite on the label for Rezdiffra that it should be used in combination with nutrition and physical activity. So what are the firewalls there that we need to go through? Our exercise specialist reimbursed? The field needs to be able to be available. That's not just something of pitching to the patient of saying, you ought to get up and get screened and get some exercise and eat better. We have to turnkey hand this to them. And that is the responsibility of the field here.
Mike Patel.
Jeff, I want to, I don't know if I'm calling you out or if I'm misreading something you're saying in there. I agree with 95% of what you said. I do think that it has to be a collaborative effort between patients and their primary care. I do think that, especially now, patients that are struggling with obesity and do have type 2 diabetes should say to their doctor at their next annual, if the doctor doesn't bring it up, hey, I'm at risk for this thing called fatty liver disease. They're not going to say steatotic liver disease, and I want to be assessed for that. I think it's on them to say that if the doctor doesn't bring it up, because it could be years until the doctors find the interest or the time to fit that into their agenda of meeting patients, because they have their 5 minutes that they have, right? So if that's what you're saying, I want to at least just add that I do think it's important for patients to have that ownership.
I totally agree with that, Michael. You're never going to have an argument from me that patients need to be more aware of their liver and educated about the liver. And I do think it's a fairly symbiotic relationship between the patients and whatever medical practitioner they're seeing, whether it's primary care, whether it's a specialist of some sort. They need to be able to have the resources and the support also so they can then be better prepared to ask the correct questions in this one.
Couldn't agree more with that. I'm going to hearken to two notes, however, Jeff, that first of all, I did not intend the question in any way to put it on patients. Okay. In fact, one of my real concerns is that patients will get activated into a system that isn't ready to absorb them, and that will present a ton of its own challenges. So I'm going to channel my inner Naeem Al-Khouri for a moment. And Naeem has come on the podcast twice in the last 6 months and expressed the same concern. Louise, help me if I get this wrong, that if in fact too many patients go into primary care, we're going to wind up getting a bunch of false positive FIB4s that push patients onto hepatologists. And then most of those patients will screen out. They'll go back to primary care. Primary care will say, this isn't working. And hepatologists will say, I'm getting swamped for nothing. And that's because we've done a really good job of activating patients into a system that isn't ready to accept it yet. Louise, did I do okay with that?
Yeah.
All right.
That was exactly it. Is what we're going to do with them was the general impression.
Yeah, so that's number one, right? And then number two is where Jeff went, which is an American issue, Mike, admittedly, but it's real, which is that if people don't get properly reimbursed, then patients are going to be putting money out of pocket for no reason, or doctors are going to be eating money for no reason, or both. So I think we're still at a point where maybe there's a foundation and a frame for the treatment process. And what the res differ approval means in part is someone's going to spend a lot more money to build the house than they would have otherwise. But we've got to floor it. We've got to roof it. We've got to do all of it. I guess, so Jeff, part of my question to you becomes, you're certainly not spoiled for lack of opportunity or lack of targets. But do you or any of the three of you see one or two particular targets that patients can influence that will have the greatest positive throw weight on pushing this whole thing forward?
Off the top of my head, to me, it's getting screened. I mean, I'm coming back to that, but getting into the system proves that there's the need, and having the liver identified within that system is going to prove that there's a need there in that. It seems to me that we have concerns over theoretical issues right now, whereas we have very real issues in the moment. That we know upwards of 1 in 3 to 1 in 4 people have fatty liver disease globally, but that's not diagnosed. That's a projected number that we have on that. And so we need to have better real numbers of people that are actually with fatty liver disease. And then that way we can also get a better idea of the scan of fatty liver disease, of where these patients should live within their own health systems as well. For me, we got to get them screened.
And now back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingmash.com. Next week, we will celebrate Stephen Harrison with some of the key opinion leaders who knew him best. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.